Good afternoon, my teachers, my mentors, colleagues, ladies and gentlemen. It gives me great pleasure to speak to you this afternoon about neurofibromatosis and the neurological complications and management in Nigeria. The title of my talk, as I have titled it, is Neurofibromatosis and its Management in Nigeria, with focus on important neurological and neurophysiological considerations. My name is Olufumilola Okun from the College of Medicine, University of Ibadan. These are my acknowledgements. I have no financial disclosures, and this is the outline that I will be following. By definition, neurofibromatosis is a genetic disorder characterized by tumors of the nervous system with or without characteristic cutaneous and ophthalmic abnormalities. It has a variable presentation and is one of the group of disorders known as neurocutaneous disorders. Indeed, it's one of also the disorders known as crystopathies, neurocrystopathies. And this is because the cells that are affected are derived from neural crest cells. The neural crest cells themselves produce Schwann cells, neurons, osteoblasts, melanocytes, adipocytes, and chondrocytes. And therefore, it is not unsurprising that neurofibromatosis would manifest with disorders at any of these levels. There are three main types: NF1, NF2, and schwannomatosis. Most of the talk today will refer to NF1 and NF2. Neurofibromatosis type 1 is also known as von Reckling-Hawkins's disease, and this is also known as systemic or multisystemic neurofibromatosis, while NF2 has customarily been known as acoustic neuroma or bilateral vestibular schwannoma, which is the preferred name today. Neurofibromatosis type 3 is the rarest and the most recently described form of neurofibromatosis, and this is the schwannomatosis. It has a lot of overlap with neurofibromatosis type 2, and I will not be speaking much more about it beyond just a brief introduction. So these different forms of neurofibromatosis are important because they have distinctly different clinical presentations and have different genetic loci. The different disease manifestations present throughout life at different times based on the age of the patient. Speaking first about neurofibromatosis 1 and 2, the gene locus of NF1 is on chromosome 17, while that for NF2 is on chromosome 22. Both of them have extremely high penetrance. However, the prevalence of NF1 is about 20 times more common than NF2. So while NF1 is found in 1 in 2,500 to 4,000 individuals, NF2 is only diagnosed in 1 in 50,000 people. Acoustic schwannomas are very rare in NF1, while they are also found in NF2. NF1 tends to present much earlier, usually in the first decade, while NF2 presents at the second decade or later. Cafe au lait spots and neurofibromas are much more prevalent in NF1 than in NF2. Iris hematomas known as leash nodules are found more commonly in NF1 and they're absent in NF2. So from the other features seen here, it's very clear that NF1 involves many systems, while NF2 is largely a CNS disorder. Neurofibromatosis type 3, on the other hand, is the rarest form of neurofibromatosis and also the most recently defined. It was described by Nomura in 1973 and is characterized by gene line mutations in the LZTR1 and SMARCB1 gene, both of which are located on the long arm of chromosome 22. and it results in slow-growing schwannomas of the cranial, spinal, or peripheral nerves. About 33%, on the other hand, are localized either to a limb, maybe the arm or leg, or just segments of the spine. And the clinical features, as I've mentioned, overlap strongly with NF2 and in fact may not be distinguishable except by genetic testing. So patients present with pain, paresthesia, motor weakness, or the said swellings, and they're treated mostly symptomatically. So the pathophysiology of the neurofibromatosis lesions is essentially related to the loss of function or loss of expression of the respective proteins that are encoded by the NF genes affected. So while in NF1, the respective protein is neurofibromin, the protein encoded by NF2 gene is myelin, otherwise known as schwannomin. And the loss of function results from the mutation on both alleles of the disorder, of the gene, sorry. The presence of just one normal allele is not sufficient for full function, and this is known as haploinsufficiency. It is in fact reported that haploinsufficiency may account for much of the neurocognitive disorders and learning difficulties associated with neurofibromatosis type 1. So with respect to clinical presentation and diagnosis, neurofibromatosis, as I have mentioned before, can present at any age, and the diagnosis is primarily clinical based on specific criteria which have been outlined. And genetic studies, though available, are rarely ordered, particularly in a place like Nigeria. Now, current diagnostic criteria, however, were defined as far back as 1987 at a consensus conference by the NIH. However, since 2017, there have been moves to update these criteria because there's now a lot of capacity for genetic testing, and there's better understanding and new clinical information that's emerging. So in 2019, a consensus conference was also held in San Francisco to discuss the updating that will be done to the existing criteria. So talking about neurofibromatosis type 1, it's the commonest inherited neurocutaneous disorder, and it affects between 1 in 3,000 to 1 in 6,000 individuals worldwide. It has an autosomal dominant mode of inheritance, but as mentioned before, there's extremely variable expressivity. Up to 50% of cases are inherited, while the other half result from new mutations, and these are called sporadic. NF1 is characterized by cutaneous nodules known as neurofibromas, which could be cutaneous, subcutaneous, or internal, and cafe au lait macules, abbreviated as CALMs. Leash nodules, as I've mentioned before, these are iris hematomas, and there's a predilection for the development of optic nerve gliomas in patients with neurofibromatosis 1. They are also known to have an increased lifetime risk of developing all other types of malignancies. And a review of death certificates shows that neurofibromatosis appears to reduce life expectancy between 10 to 15 years, more so in females than males, and this was found in a large study in France. Neurofibromatosis affects virtually every system of the body and therefore can present to any medical specialty. So it's important that people know the implications of making a diagnosis of neurofibromatosis 1. Neurofibromatosis 1 can be diagnosed using the following diagnostic criteria. And 2 or more of these criteria is required for a diagnosis. At least 6 or more cafe au lait macules. If it's in a child, these should measure 5 millimeters or more, while they require larger dimensions to be important in adults. So usually the size of 15 millimeters in adults is considered diagnostic. And 2 or more subcutaneous neurofibromas, or 1 plexiform neurofibroma, which is usually much, much larger and feels like a bag of worms. There could be axillary or groin freckling, or indeed freckles behind any of the flexure areas on the skin. An optic pathway glioma is also useful. 2 or more leash nodules. Just important to mention here that leash nodules are rarely present below adolescents, and so therefore they will be more obvious in adults and more useful for diagnosis at that stage. And the other criteria are as listed. These are some of the neurocutaneous manifestations of neurofibromatosis, one that we have seen in practice. The bony deformities include pseudoarthrosis of long bones and dysplasia of long bones. And so things like geniovalgum, varum, anterior bowing of the tibia, and the presence of dermal neurofibromas, which are usually smaller and firm, soft, non-tender. Plexiform neurofibromas that can occur anywhere. We will talk about the areas and locations of occurrence shortly. And these are leash nodules. They are light on dark colored iris and dark on light colored irides. Intracranial tumors, and we've talked about notably the optic nerve or optic pathway gliomas. And the neurofibromas, when very large, can become pedunculated, as seen below here. Bony dysplasias have been described in Nigerian patients with neurofibromatosis. This was an interesting case reported by Kimolado and Michael of a 27-year-old female who presented with multiple scalp and cutaneous swellings, a huge plexiform neurofibroma in the orbital and periorbital region. And we can see here from this axial bone window non-contrast CT scan that there was a defect in the temporal wall posteriorly of the orbit there, with a protrusion of soft tissue. There's also a huge defect in the occipital bone. And you can see the same, another defect here posteriorly. So thinning of bones with defects in cortical bones is common in neurofibromatosis. Here we have pseudoarthrosis of the 5th digit, and you can see the cystic change with bony erosion in another patient with a similar deformity reported by Ademulu and Ijadola. So neurofibromatosis type 2, on the other hand, as described by Wishart et al., is very rare, also autosomal dominant in inheritance, with more than 50% being sporadic and having a very high incidence of mosaicism. Therefore, there can be segmental or very focal areas affected by neurofibromatosis. And so we could find a patient with just the bilateral acoustic neuromas and no other features. So neurofibromatosis 2 is characterized by bilateral or unilateral vestibular schwannomas and a preponderance of other intracranial tumors, notably meningiomas, ependymomas, as well as presence of peripheral, cranial, or spinal schwannomas. And we mentioned that mosaicism can result in just localized disease, and therefore it might even be missed. There are two main clinical presentations: a more severe and aggressive form known as the Wishart type, and a very mild form known as the Gardner type, which in fact may remain asymptomatic throughout the patient's life. And NF2 should be followed up because of the propensity for intracranial tumors. These are the criteria for diagnosis, known as the Manchester criteria, described in 1992. And here are forms of the acoustic neuromas. So we can see bilateral vestibular schwannomas in this patient, and less clearly in this CT scan than in an MRI. So here we have just a subtle change showing splaying of the internal auditory canal and a hypo dense mass in the area of the vestibular nerve. So just a note that MRI with contrast is preferable to CT scan for imaging of patients with suspected NF2. And here we can see that it's quite difficult to see these lesions in this patient using CT scan. While with MRI, it's much, much easier to see. The clinical associations of NF1 and NF2 are as listed, just as I mentioned before. Optic pathway gliomas are commoner in NF1, while you have more vestibular schwannomas in NF2. Leash nodules, commoner in NF1, while you have more posterior subcapsular cataracts in NF2. The reason for that is not really clear. So what are the neurological complications of neurofibromatosis? We've talked about the increased number of tumors, but in terms of presentation and symptoms, patients are found to have a lot more headaches. We can find a lot more of them having epilepsy and cognitive impairment. In fact, unidentified bright objects, which are considered to be related to the prevalence of cognitive impairment, are T2 weighted hyperintensities found sometimes incidentally on MR imaging of the brain in neurofibromatosis patients. Looking at a literature review of the different authors that have looked at neurological complications, Crayon et al. Were the first to describe neurological complications in neurofibromatosis patients. They looked at 138 adults and 20 children aged 11 to 77 years with a mean of 33 years in the adults. And they found that neurofibromatosis was sporadic in majority of them, 53%, and optic nerve or optic pathway gliomas were the most common tumors, while headache was the commonest symptom. Ruggieri did a literature review and identified that neurofibromatosis neurological complications, while being common, are mostly mild and bearable for the individuals, and they're only severe in just about 3 to 8% of individuals. Shea in Taiwan looked at 69 patients, and a majority of them also had CT scans, and it was found that while the neurofibromatous bright objects that I've described earlier, the T2 hyperintensities, were found in up to 14 out of the 69 patients. Epilepsy and cerebral infarcts were the commonest presentations apart from the tumors. But the significance of these hyperintensities on T2 is not related to the severity of the presentation of any of these patients. And more recent reviews have identified that meningiomatosis and glial hematomas may be novel associations with NF2. What are the differential diagnoses of neurofibromatosis? We have to remember the other phakomatosis, and these other syndromes are considered variants of neurofibromatosis. So I would summarize by saying that the management of neurofibromatosis is mainly age-specific surveillance for the known comorbidities and tumors and long-term follow-up. But it's important to emphasize that the management should be done by a multidisciplinary team. We have a suggested protocol here for screening for the neurological complications. Optic pathway gliomas, they are commoner in children, and in fact, it is said that after adolescence, these tumors rarely become symptomatic or progress. So therefore, it's important that children should be screened for these tumors in at least the early years to their late teens. However, it has been clearly found that it's not necessary to scan every child except they become symptomatic. However, they do require regular neurological and ophthalmic assessment. And importantly, physicians, pediatricians, ophthalmologists, neuro-ophthalmologists will be very important personnel involved in doing this screening. The developmental delay and learning difficulties, they present very early, they're very common, and should be screened for. And they've been found to have a lot of visuospatial challenges and a little bit more challenges with calculations than they have with verbal reasoning. And so children should be screened by educational specialists and pediatricians very early to be able to identify these learning disorders and taken care of. Epilepsy, hydrocephalus, stroke, headache are important to be screened for by pediatricians, neuropediatricians, neuro-ophthalmologists, and neurologists. And nerve compression, which is more common in adults because of enlargement of the nerves, should be screened for, asking for history of pain and undue rapid growth, particularly considering the possibility or potential of malignant transformation of neurofibromas. And this should be done at every visit by the neurologist, the neuro-ophthalmologist, and any physician that sees neurofibromatosis patients. However, social and professional integration should be encouraged, and occupational specialists and social workers are very important people to do this. Other problems that they may present with, chronic pain that can affect their quality of life, and the psychological impact of the disfigurement that they may have should always be inquired about when seeing patients clinically. And the important personnel to do this include not just the physicians, but also parents and teachers should be sensitive to the need to identify these problems and take care of them. Deafness and speech difficulties should require regular ENT assessment, and therefore pediatricians, family physicians should be aware of this, teachers and parents as well. And this patient at least should see an ENT specialist once in a year or once in a couple of years. The most dreaded complication of neurofibromatosis is malignant transformation of the neurofibromas, or a de novo presentation of malignant neurofibroma, previously called neurofibrosarcoma and now known as MPNST, otherwise known as malignant peripheral nerve sheath tumor. And it's important to always ask about recent increase in size, particularly of plexiform neuromas, appearance of undue pain, any change in the surface, ulceration or bleeding from any of these tumors. And it's important to manage the patient accordingly. So what is the Nigerian experience in neurofibromatosis? There have been numerous case reports about different presentations, but a few small case series have been done, and these are published in local and international journals. The very first case series was done by Ademiluyi and Jadwola in Lagos, and they looked at 14 children. Odebode did a larger case series in Ilorin involving 98 cases. So Ademiluyi and Jadwola looked at 14 cases, and in fact, some of the most important findings he reported are the fact that cafe au lait spots are often very difficult to identify in the black-skinned individual, and in fact may more appropriately be called cafe sans lait spots because they are mostly hyperpigmented macules. The commonest type of neurofibroma that was found were the plexiform neurofibromas. Unfortunately, none of these patients had neuroimaging. While in Odebode's case series, he found benign tumors in majority of the patients he saw. They presented mostly with plexiform neurofibromas and subcutaneous and cutaneous neurofibromas, but there was a 3.1% mortality due to malignant peripheral nerve sheath tumors. The majority of lesions were located in the head and neck region, and at least 2 of his patients had neuroimaging. They had CT scans, but no optic nerve glioma was found in any of them. Yandeti in northeastern Nigeria also did a series on 47 patients, also finding cutaneous neurofibromas and plexiform neurofibromas in majority of his cases, with a high incidence or prevalence of cafe au lait spots. Most lesions also were found in the head and neck region, but none had neuroimaging. So we don't have much by way of reports of neurological complications. There are other individual interesting case reports, and in fact, there was a case report of HIV coexisting with neurofibromatosis, and it was found that the HIV did not adversely impact the neurofibromatosis. Neurofibrosarcoma, as I've mentioned before, that's malignant peripheral nerve sheath tumor, is the major cause of death in patients, and it's found that most Nigerian patients present late with this disorder. What has been my personal experience with neurofibromatosis? I find that it's a very common condition, but interestingly, most patients don't present primarily because of their neurofibromatosis. They present with some other complaint. And in fact, they rarely present except they have unbearable symptoms. Common findings that I have is that most patients have disfiguring proptosis, plexiform masses. Leash nodules are very, very common on the iris. And I'll just share 2 illustrative cases that describe the challenges we have with diagnosis and management. So case 1 here describes diagnostic challenges, and this refers to the neurological complications that you can have with neurofibromatosis. The cost and access to neuroimaging is the major limitation. So we diagnosed neurofibromatosis for the first time in a 10-year-old boy who presented with ocular symptoms completely unrelated to the neurofibromatosis. And coincidentally, that patient was found because of papilledema. He was found to have a very huge intracranial mass, which was treated and which we referred him for treatment for. So this is the patient. He presented with a 9-month history of redness of the right eye, and you can see the vision, the eye is red. He had actually lost vision completely. Vision in that eye was NPL. And then he complained of decreasing vision on the left. Vision on the left was about 618. On the right, he had a cataract. The eye was soft, and there was a retinal detachment. We couldn't see beyond. The retinal detachment was diagnosed on ultrasound of that eye. However, he was found to have swelling of the optic nerve head in the left eye. And while questioning, I noticed that he had this hyperpigmented patch on his forehead. And that led to a line of questioning that identified a tumor that had been on his leg and had been removed. It recurred and was removed again by surgeons, but they had never done a histology. Based on the papilledema in the left eye, he had neuroimaging and we found this huge tumor. So what are the lessons from that? We find that Nigerian patients give very limited clinical history. So you require keen observation and patient inquiry, and you might be surprised by the results you get. The problems that they usually present or focus on may not be as life-threatening as the other problems that they have failed to mention. And one important point is that you should never discard human tissue without histological confirmation of the diagnosis. This patient could have been missed if we did not do neuroimaging, and indeed, the diagnosis could have been made earlier if the tissues had been taken to histology. This is the second case. Indeed, this was a 16-year-old boy. He presented with a 10-year history of poor vision. He had been given spectacles over the years and this time was being referred by an eye specialist to the low vision clinic because he had failed to improve with spectacles. The boy himself didn't give much history. He couldn't remember when last his vision was good. His vision was count finger in one eye and hand movement on the other. So obviously he was not coming for recovery of his vision. And the referring doctor already knew that he had pale discs. So there was nothing new that we were going to contribute, or was there? So looking at his mother, she had these interesting nodules on her face, on her forearms, and these are the photos showing the mother. We decided to investigate him further. We looked at the mother on the slit lamp and found leaf nodules. The patient too was put on the slit lamp and I found leaf nodules. So looking at the back here, you can see that he has barely perceptible cafe sun-lay macles, while the mother has clear-cut neurofibromas. One would ask, would you image this child? Well, based on the fact that he had this bilateral optic atrophy, decided to image to exclude an intracranial tumor. And here we found enlargement of the distal part of the optic nerve on the right, extending all the way to the chiasm and the tuber cinereum. And not just involving the right, but even on the left, in the optic tract, there was enlargement and there was involvement. So he had bilateral optic pathway gliomas. So indeed, we were able to make the diagnosis, but then because of the fact that we are limited with our rehabilitation, management was suboptimal. So what's the take-home message? Neurofibromatosis is a ubiquitous and protein disorder with potential to severely impact the growth, development, health, and quality of life of the patients and their families. More than 50% will develop neurological complications at some point in time. However, routine radiological screening is not required, whilst neurological or neurophthalmic assessment is required clinically. However, Nigerians tend to present late and sometimes with very severe disfigurement or with malignant peripheral nerve sheath tumors that can be fatal. Screening of cognitive impairment in Nigeria is still suboptimal. However, the importance of a multidisciplinary team approach to the management of these patients cannot be overemphasized. Just a final word for those who might be taking exams. Watch out that the diagnostic criteria for neurofibromatosis may be changing very soon. These are some of my references, and thank you for your attention.